leading to only a deficiency in RBC, or if there is deficiency in other cells as well. So first thing we need to look for is if it is a single lineage problem or if other lineages are also involved. Now in anemia for adult, how I remember it is, when you're menarche, right? That is 13 years, but then that's for adult guys, whoever, since they have testosterone and all, their hemoglobin is supposed to be higher than females, and it becomes lesser in pregnancy because of hemodilution. Now these are values that you can't do anything, you need to by heart. Okay, now let's come to uh, classification of anemia. There are mainly, there's only two types of anemia when you think about it. One, if anemia due to hyperproliferation, and one more is anemia due to hyperproliferation. See, what is proliferation? It means that the amount of red blood cells has increased. If amount of red blood cells has to increase, that means some precursor of red blood cell will also be high, no? So what is that precursor? That precursor is nothing but your reticulocyte. So how do we measure? How do we make it easier to classify into hypo and hyper? Is just measure the amount of reticulocytes that are there. Okay, now I'll just show you a picture of what a reticulocyte looks like. Can you all identify it? Okay. And then this is basically just a schematic form to know how your erythrocytes are produced. I'll just tell the brief, I'll tell briefly about how it is. Okay, now we have your kidney. Kidney finds, in kidney there is some cause like hypoxia, some cause, something that is causing hypoxia. In your interstitial tubular cells, there is hypoxia. This in turns releases your erythropoietin. This erythropoietin goes and stimulates your bone marrow. Once it stimulates your bone marrow, what cells are there in your bone marrow? You have stem cells. Okay, I'll ask you one question here, you guys should answer. In bone marrow there are stem cells. Can these stem cells develop or structures like skeletal muscles or nerve cells? Yes or no, guys? No. Anyone else? If yes, why yes? Okay, I'll tell you. The answer is yes. You have stem cells, right? Yeah. Yes, yes. You have stem cells, right? They have the potential to develop into your neurons or your skeletal cells or anything. And then what they're trying to do nowadays is they're trying to find a way to give signals to your stem cells to make sure that they can develop into your neurons or skeletal cells, something like that. Now you let's come back. Your bone marrow, yeah, here there is your stem cell. This stem cell will get its signal, and it will form a pluripotent cell. That is your pluripotent cell is your stem cell. It will form a blast cell. It will differentiate into a blast forming unit. This blast forming unit further differentiates into colony forming unit. What does it do? Colony forming unit. Here it differentiates into the early normoblast, late normoblast, and then into your reticulocyte, and then finally it gives your erythrocyte. Okay, now two things that you need to remember from this. All you need to know is, from reticulocyte to RBC, how many days does it take? Any guess? Reticulocyte to RBC, how many days does it take? Yeah, correct. 3 days, 3 days, 3 days. What is your lifespan of RBC? 120 days. Okay. Now, what is the speciality about your reticulocyte is there a nucleus or no? In late stages, is there a nucleus or no? Yes or no? No, correct. Then what are the values over here? DNA fragments, RNA, anything else? Mitochondria. Can it be mitochondria? In RBC, there is no mitochondria, right? But then in your reticulocyte, there is mitochondria. So what I drew there is your mitochondria. Okay. Now let's go to the next time. So what? So all we did was Aishwarya. All we did was we just discussed how what are the types of anemia that are there. That is your hyperproliferative and hyperproliferative. How do you tell? Based on the number of reticulocytes, you differentiate these two. Okay, and then I showed them what the reticulocyte was, and then basic physiology and what you need to know about your reticulocytes, and a little bit about RBCs. So how many days? We had 3 days to go from your reticulocyte to RBC. Okay, how do you identify your reticulocyte? Is you use something called a supravital stain, and on this stain, when you use brilliant crystal blue or new methylene blue, that is why this part is there, no, in your reticulocyte. It takes up the color and it appears as blue. That is why everywhere you see it is blue. Okay, now what is the normal amount you are supposed to find? It is about zero point 0.5 to 1.5%. That's all. Zero point 0.5 to 1.5. If it is more than 1.5, what do we have? We have hyperproliferation. If it is less than zero point 0.5, what do we have? We have hypoproliferation. So till here, everyone understood? Yes or no? Okay, I'll continue. So how do we calculate your, there is see few indices that we need to know. See, we stress so much about your reticulocyte count, right? So we need to know how do you what are the indices that are there, and how do you calculate the amount of reticulocyte. There is something called reticulocyte proliferation index. What does this measure is? This is, let's say, a 75-year-old man, a 75-year-old man or a 73-year-old man with hemoglobin of 7. What so he has 7. What he is supposed to have is 15. 15 is the standard that we all agreed upon, right? He has 7. Now what has happened is, since we are taking 15 as a standard, do you think when the hemoglobin is 7, won't there be dilution? There will be dilution, right? And then when you take the hematocrit and then you take it for 7, you will be overestimating the amount of reticulocytes. So if they give you in a question that reticulocyte, we saw that there was 6%, there was 6% reticulocyte. Is this a correct reticulocyte count? No, this won't be your correct reticulocyte count. So to make sure that we approach the right reticulocyte count, we have to have certain derivations. Very simple. Why we are deriving is because, let's say, the amount of RBCs in 1 liter is supposed to be 60%. Okay, now you have decreased the amount of RBCs. So there will be, so you will feel that when you take a small sample, there will be more reticulocytes compared to your cells of RBCs. Okay, so how do you change it? Very simple. How I remembered it was, whatever hemoglobin they've given, and take a difference between how much you're supposed to get and how much you're supposed to have. Wait. Sorry. I'm so sorry. So you just take it like a percentage. How much is there by how much you're supposed to have? How much is given? That was 7 by how much you are supposed to have. That is your 15, right? And then you take your reticulocyte count, whatever that was given, that was 6, and then divided by 2. This gives your reticulocyte proliferation index. But then is this enough? Reticulocyte proliferation index does not mean that it is just giving you the corrected reticulocyte count. To get your corrected reticulocyte count, you just need to multiply by 2. Did you understand the formula, guys? Okay. Now we have done with your proliferation of anemia. Basically, we have done with reticulocyte. Now we are seeing in your hypoproliferative anemia. What does it mean? That means the amount I'll start off with a question. You have hypoproliferative anemia. Hypoproliferative anemia. What will happen to your bone marrow? Will will there be increase in cells, erythro cells, or will there be decrease in the cells in your bone marrow? Increase or decrease? A is increase, B is decrease. And option C is there can be both. First, they'll what guys? You have anemia, hypoproliferative anemia. Will there be increase in erythrocyte production, or will there be decrease in erythrocyte production? And what will happen to your bone marrow?
What do you mean by hypoproliferative?
Hypoproliferative is anemia. No. See, hypoproliferation means the amount of, see, hypoproliferation means you have your marrow, and then because of decrease in cells, there is decrease in RBC. This can be one thing. Hypoproliferation means whatever. I'll give you a simpler answer. Let's say you have anemia, right? You have increased stimulus for production of RBCs. Now your body can have two response. Either it increases production of RBCs or it decreases production of RBCs for some reason. If it increases the production of RBC, then then it is hyperproliferation. If it is somehow decreasing the production of RBCs, it is hypoproliferation. Did you understand?
Okay.
Yeah, there has to be increase in production first. Then what will happen? If I tell there will be first increase in production and then there will be decrease in production, is it right? It will first be a hyperproliferative it will first be an hyperproliferative marrow, and then it will become a hypoproliferative marrow. See, your body, whenever whatever situation comes, right, it needs to make sure that some amount of your RBCs are present, right? What does it do? Your body has something called compensation. Your body tries to compensate. In any case of anemia, you have stimulus, right? You have stimulus initially. This is stage one. Initially there will be a stimulus to your bone marrow, and then there will be hyper proliferation and there will be more RBC production. Initially it will try. It doesn't mean it will succeed, it will just try. But then in stage 2, after certain time, what will happen is there this thing is not sufficient, right? That is why you have anemia. Sure. So this will end up in hypoproliferation. So first you will start off with hyper proliferation, then it will become hypoproliferation. Did everyone understand this? It will start off as hyper proliferation, later on it moves to hypoproliferation. Okay, then we need to talk about what this hypoproliferation will lead to. Few things, very simple. Will it be macrocyte, normocyte, or microcyte? Anything. What is MCV? Mean corpuscular volume. That means if you take all the RBCs and then you take a mean of, then you calculate the volume of them, and then when you take your mean, that time what value you get, that is the value you use to tell how big the RBC is, because for you're considering volume, right? Mean corpuscular volume. So it just tells you a single RBC how big it is. Now if at all it is above 100, then it's a macrocyte. If it is 80 to 100, it is normocyte. If it is less than 80, it's a microcyte. Okay, now we'll talk about iron. You have 100% of iron. Okay, and how do you distribute in your body? That is our main question. Okay, if at all anyone can answer, iron, where is it stored? Like, where is iron most? Hemoglobin. Anyone can answer that? Hemoglobin. Now in storage, that is iron, right? 65% is hemoglobin. Now in storage, how much percent is what? 57 in from 65 you have 25% as stored, stored form. In that, ferritin is the most. And when you have more ferritin, what happens is this ferritin is not that stable. We'll call it as a big compound. this ferritin is not that stable, so it later on forms, it breaks down and forms hemosidrin. Okay, this is not that stable, this is more stable. So so we can derive the properties, it is more stable. If it is more stable, will it be more soluble or less soluble in water? Obviously it has to be less soluble in water, it's not that reactive, right? So that was a property we derived from ferritin to hemosidrin. Now, since you need to have a lot of ferritin to come to hemosidrin, we can easily tell which is more in number. Obviously, ferritin has to be more in number, right? Okay, that is how we could say in storage, ferritin is the most, then is hemosidrin, then around 3 to 4% is in your myoglobin. But then one thing that you need to by heart here is around 0.08% is your transport. It's in your transport form. Okay, now we'll come to diet. Why is this so important is because they'll tell you required daily what is that, recommended daily allowance, and how much your body requires, how much of iron your body requires to make sure all the properties are, all the functions are cleared. Okay, now when we take that, if you take 10 milligrams as elemental iron and you consume it, only 10% is absorbed. Okay, that is why when they tell your body needs 1 milligram, what will you recommend to your patient? Will you recommend will you recommend him, will you tell him to take only 1 milligram, or will you tell him to take 10 milligram? Obviously you need to tell him to take 10 milligram, right? Now how much is required, who requires the most? Pregnant women. So they have three, so they pregnant female, right? So she should have the highest, that is why she requires 3 milligrams. And then next is female, 2 milligrams. Adult is 1. Infant is similar to adult because infant is growing a lot, right? That is why he requires more. And then child is about zero point 0.5. Child you consider like teenagers. Okay, teenagers like below 12 years, like 12 years up that range, that for them you need zero point 0.5 milligrams. Okay, now we'll come to the most important part. This is where your physiology is really important. I told you 10% is absorbed, right? And you're giving 10 milligrams. He is absorbing 1 milligram. Okay, now in which form? In that also, not all iron is the same. People who are, see, only vegetarians, they have one, they'll have an issue because heme iron is in Fe2 plus. This Fe2 plus is gold. Non-heme iron, which are vegetarian seed, is Fe3 plus, right? That is why most of them end up with some deficiencies. Now, is all iron is the same? No. The type of source we get it from, if we get it from a non-vegetarian source, the time it is in Fe2 plus. If at all you get it from a vegetarian source, it is Fe3 plus. On this planet earth, are there more vegetarians or non-vegetarians? There are obviously more vegetarians, right? That is why around 75% of our diet, or even when you consider yourself, 75% of the time you'll be consuming your vegetarian food. That is why around 75% of your diet will be non-heme, and only around 25% of your 25 10% will be your heme. Now we'll see how your absorption happens. Where does it happen? It happens in your the iron is absorbed in your intestine. Where? In your duodenum or jejunum. Okay, now we'll discuss about how this happens. Why I told you iron is not this, why I told you iron also discriminates, because your cells, see, this is your intestinal, this is your duodenal cell. What is this? A duodenal cell. If you see the lateral, if you see the luminal part, this is called the apical part. Okay, and then when you see so if this is, here is your lumen, This is so whichever side is close to your lumen, that is called your apical part. Whichever side is away from your lumen, that is called your basolateral part. So you have two parts. One is your apical part and the other one is your basolateral part. Since iron is not made the same, this is heme iron. This heme iron can easily enter because it's in Fe2 plus. Now, since a lot of people are already what is this already consuming Fe3 plus, all you need to do is simple convert it into Fe2 plus. We'll name this enzyme. What we'll name an enzyme which converts Fe3 plus to Fe2 plus. From 3 plus 3 to go to plus 2, what is this process called? Reduction, right? Where is this reduction happening? In the duodenum. It's happening in the duodenum. It is a reduction process, so you have to mix these two. That so the enzyme will be called, anyone can answer? Duodenal cytochrome b reductase. Okay, this duodenal cytochrome b reductase converts your Fe3 plus to Fe2 plus, and this Fe2 plus is a divalent ion. So, since this divalent ion is there, there is a receptor for this. There is that receptor is called divalent metal transporter 1. Divalent metal transporter 1. Will it transport only Fe2 plus? No. Any since the name only has no divalent metal transporter, it can transport any metal which has a divalent charge. Okay, now it will come. Now this Fe2 plus has come inside. If you don't use it, if you don't use your Fe2 plus, it has to go somewhere. That it either has to go out or it has to be stored. This will be stored as Fe3 plus. Fe2 plus is again converted back to Fe3 plus and it is stored. So what do you call this? Fe3 plus is ferric, right? So you call it as this has to be there. So it has to be a ferritin stored. Ferritin stored. Now I'll ask you one more question. What are the sites for storage of your Fe3 plus? Where all will it be stored? Is it only the duodenum? I was talking about duodenal cell. Can it be stored in any other cells? Just tell yes or no. Okay. Yes. Yes. How many sites? In total, how many sites? One, two, three. It's only till three, or four, or five. Okay, we have three sites. One is your duodenum, one is your bone marrow, one more is your macrophages. Right? Now your Fe3 plus. I'll just repeat what all we did. We had Fe2 plus and we had Fe3 plus. Your intestine can absorb only Fe2 plus because it has a receptor called divalent metal transporter 1. So there has to be, okay, fine. So there has to be transport. Fe2 plus is transported. This has to be stored. Yeah, I guess so. This has to be stored as Fe3 plus. Now, since storage is not enough, you need to make sure it when it comes out, it should leave as Fe2 plus. Remember, your intestine, all it can take is Fe2 plus, so it has to send out Fe2 plus. Right? Understood? Now, once it comes out, this Fe2 plus will have to bind to a transport protein, right? But then this will not bind to transport protein in the form of Fe2 plus. It has to bind as Fe3 plus. So you have an enzyme called hepastatine. Okay, this converts your Fe2 plus into Fe3 plus. So what is your hepastatine doing? It is converting your Fe3 plus into Fe2 plus. Since it is going out, this Fe2 plus is going out. No, it has to have another port that is called ferroportin. It is going out by your ferroportin, then binding to your hepastatin, changing into Fe3 plus. Now, since this Fe3 plus is there, this Fe3 plus will this Fe3 plus will bind to your transferrin, and that get transported to your bone marrow, or it will just stay there. Now, like I said, if the stores are filled, what will happen? This ferritin excess will be converted into your hemosiderin. So, what all did we learn till now? How it goes in, how it comes out, how it is stored. If there is excess, what happens to that excess? Okay. Any doubts till now? In brain, one important point is in brain you don't have hepastatin, you have ceruloplasmin. Okay. In brain, what do you have? But does the function change? No, the function doesn't change. In brain, whatever hepastatin does, same thing ceruloplasmin does. Okay. Now let's talk about what is important in your picture. If at all I'm talking about serum ferritin level, what does it mean? It means how much of Fe3 plus I'm about to store. I can store. In simple words, how much of iron am I able to store in cells? So that has a value that is your 30 to 300 nanogram per ml. Okay, that is your serum ferritin. What does serum ferritin mean? It means how much of iron can you store. Then what is serum iron? What did I tell you? When it comes out, it comes out as Fe2 plus. This Fe2 plus is converted into Fe3 plus. This Fe3 plus is bound to your transferrin. What can I say? So whatever iron is there in serum will be bound to your transferrin, right? How so? If I'm calculating how much is my serum iron, I'm saying is how much of iron is there in my plasma running around bound to transferrin. Understood? Then we have one more value, that is my TIBC. TIBC means how much affinity, like how desperate am I to absorb iron. Okay. If at all I already have a lot of iron, will I be desperate? No. Right. So what will I do? My TIBC will be low. If at all I have very low iron, that time I'll be more desperate. I'll have more affinity. I'll want to bind to iron. So all my TIBC is saying is how much, like how desperate am I to bind to iron. Okay. Then what is transferrin saturation? So what did I tell you? So I'll give you an example. Will you have a lot of iron or will you have a lot of transferrin? One is you'll have a lot of iron. Two is you'll have a lot of transferrin. Normally in your body, it's a question, guys. You need to answer one or two.
Two.
Yes. Why? See, what did I tell? I told when iron is there, you have your duodenal cell, iron is coming out. This iron is coming out and binding it to transferrin. That means there is already that much availability of transferrin. Okay. So we can say now that there is more transferrin than iron. Okay. Now when we take a ratio, or when we take a ratio, how much, what was serum iron? How much is coming out? And what is my TIBC? How much is getting bound? So when I say the iron, and how much of TIBC I have, when I TIBC is how much transferrin I have. Very simple. How much iron has come out by how much transferrin is there, and if I take a percentage, that will tell me that about one third will be my serum iron. Okay. That is why my transferrin saturation, all it says is how much of transferrin is bound to my iron, right? Did you guys get it? Now if I tell, see, one thing you should know is serum ferritin is also a marker of inflammation. So you can't, only by these values you can't diagnose anything. You should be very careful with that. Okay. And do I have to repeat this? Did everyone get absorption? Because absorption is really important. If you want me to repeat, I'll repeat. Okay, we'll come to the other part. This is an interesting part. For this, what I'll do is I'll take my whiteboard. Now I have our boss. This is liver. Okay. What does this liver do? This liver can secrete a peptide that is hepcidin. Hepcidin. What this hepcidin does is, I told you the site of absorption is your duodenal cell. What in your duodenal cell? The main reason is that dimethyl transferase. Okay, dimetal divalent metal transferase 1 is responsible for absorption. Now, for it to release, it is going through what? Ferroportin. It is going through a port, that is ferroportin 1. What this hepcidin does is, this hepcidin basically down regulates your ferroportin. Now, I'll give you a scenario. If at all I have a mutation, this mutation will decrease the production of hepcidin. So, what will happen to the serum iron levels? Will it A, increase, or B, decrease? A or B? Hello, guys. It has to
B.
increase.
Oh, okay.
See, I told you hepcidin is released by your liver. This hepcidin is down regulating your ferroportins. Down regulating means it is decreasing the number of ferroportin. What is ferroportin? What is the role of ferroportin? Its role is to take out Fe2 plus, right? And since there are more Fe2 plus, since there are less Fe2 plus, since there are more Fe2 plus, because there is no hepcidin, I will have more of iron. Understood? Okay. Now, what was that condition I spoke about?
But that is not like the transportable form, right?
No, all I asked was serum iron, right? See, it need not be transportable form. All I'm saying is, if you have no Fe2 plus coming out, will you have Fe3 plus? No, no. You need a raw product. You need raw goods to make a product, right? That is what it's doing. If at all you're decreasing the supply, there won't be there won't be much iron. So what condition did I speak about? This condition is called hemochromatosis. Okay, I'll just do a recap. See, your hepcidin is coded by uh, these three genes: HFE, hemojuvelin, and TFR2. If there is a mutation, if there is a mutation in any of these, if there is a mutation in any of if there is a mutation in any of this, and this mutation has caused decrease in hepcidin levels, that will in turn increase your iron. If there is so much iron, that is called hemochromatosis. Understood? Any doubts over here? Okay. Down regulates ferroportin and hepcidin. If you have less, so basic thing is, if you have less hepcidin, then more iron. If you have more hepcidin, then less iron is coming out. Okay, everyone understood? The main aim of this was, first I wanted you to know the importance of reticulocytes. Then I wanted you to know the type of how iron is absorbed. Then I wanted to know a condition called hemochromatosis, which is a result of mutation in a gene which decreases the production of hepcidin. Okay, now we'll go to anemia of chronic disease. What is anemia of chronic disease? Very simple. You have a chronic inflammatory state. This is causing increase in interleukin production. This interleukins, what they do is, they increase your hepcidin. See, this interleukin goes and acts on your liver, and it releases a peptide. This peptide is nothing but your hepcidin. Since we read that increase in hepcidin, what will happen? Decrease in iron, right? So iron is stuck inside. It is not coming out. Why is it important that iron doesn't come out? Because we don't want your microorganisms to use your iron, right? That was one reason. So you'll be in an anemia of chronic, and but then since you're decreasing, I think someone has unmuted. Okay. So okay, yeah. I'll just repeat. You have chronic inflammation. This increases hepcidin. This makes sure your iron doesn't come out. Now we need to focus on few things. I told you what the markers are, and now I want you to tell me what will happen to each marker. Okay. Now we'll talk about serum ferritin. What was serum ferritin? How much is bound, right, to your transferrin, and serum iron is sorry serum ferritin is serum iron is how much is bound in your, this is your stores, how much is bound, this is bound, this is your stores, and this is your affinity. Now when we talk about anemia of chronic disease, I told you that hepcidin has increased. Since hepcidin has increased, will there be reduction in the stores? Iron is not coming out, no, you're not letting iron to come out. So what will happen? The stores will be normal. It can even increase. So anemia of chronic disease, you need to note that your stores are always normal or increased. Now you tell me what will happen to your plasma iron or your bound iron when it comes out. This bound means it is bound to your transferrin. Will it be more or will it be less? It has to be less since it's not coming out. Now it is not coming out. What will happen to your TIBC? TIBC is nothing but how desperate you are to get iron. See, your stores are already full. Will you want more iron? No, right? So your TIBC should be low. This is the main difference between anemia of chronic disease and iron deficiency anemia. Iron deficiency anemia, you have less iron because of many causes. Decrease in absorption, increase in what do you say, increase in loss. So when you have iron deficiency anemia, decrease in iron, this will lead to increased stimulation, but then your bone marrow is not able to produce, so you'll have less RBCs, right? Now this is one part. So will there be less stores or more stores? Why is it not able to produce? Because your iron is not there. Your stores will be low. Your stores are low. Iron deficiency, obviously, if iron deficiency is there, will there be enough iron for your serum? No, your serum also will be low. Since you have no iron, you're one big there, right? So what will you do? You'll feel like you will be very desperate. That is why your affinity will be high. What is this? This is just a ratio between serum iron and how much of transferrin is there. If your transferrin is increasing a lot, what will happen? The denominator is increased, so your numerator will become low. So the value will become low. That is why it's negative. Understood? That was iron deficiency anemia, and this is anemia of chronic disease. Did you understand anemia of chronic disease, guys? Oh, okay, cool. Yeah, that's all I wanted to do today. You can pause, Aditi. Anemia of chronic disease ಆಯ್ತು. Anemia of chronic disease ಅಲ್ಲಿ ಏನಾಗ್ತದೆ ಅಂದ್ರೆ you have inflammation. Okay, since you have inflammation, you will have inflammatory cytokines. One of that is, and interleukins, interleukin 6. What is this job of interleukin 6 is, it will go to your liver and it will stimulate the production of this peptide called hepcidin. What did I tell you the function of hepcidin was? Go to your duodenum and tell, no boss, stop your production of these receptors called ferroportin. What is this job of ferroportin? To increase the serum iron. Okay, understood. You have inflammation. This inflammation led to the production of hepcidin. I think the doubt is the function of hepcidin. The function of hepcidin is, the nature is only to decrease your ferroportin. Okay, now this is the concept. Let's talk about the markers. In general, we'll talk simple terms. Iron is here. Okay, can this iron go out? You need to answer me yes or no. Can this iron go out if there is
No.
no more hepcidin? No, right? Now tell me what will happen to ferritin, serum ferritin. Leave serum. Tell me ferritin. Ferritin andre ಏನು storage. What will happen to your storage? Will it decrease? No, no,
No.
it's not able to go out. So how much
Yeah.
ever stored, how much ever there is storage, it will stay so much only. No, so it, when we talk about how much ferrit storage is there, it will be normal or it can be increased. Your storage problem done. Now papa plasma, your transferrin molecule is there. Is there enough iron outside in your plasma for it to come and bind to your transferrin? No, right?
Yeah.
Yes, so it's not there. So what will happen to your serum iron? Serum iron will be less. Serum iron will be less. Okay, now your TIBC, how desperate you are. If you have already stored and accumulated your food, will you want more food? No, you are not desperate. That is why your TIBC, total iron binding capacity, will be less. Okay,
Okay.
now we'll see here. Serum iron by transferrin. What will happen to this ratio? Serum iron is less. It's becoming less. This is kind of TIBC. Okay, this is also decreasing. So overall, even if we say if it increases a bit, this will predominate, right? What will you have? You will have decrease in your transferrin saturation. Okay, understood. I'll give you values if you want an example. See, serum iron was 3. This became, now let's say your transferrin, how much ever transferrin is there, that is around 8. Okay, now I'm telling your serum iron has decreased. Okay, let's say it has become 1. And then how much ever your value of TIBC is this 1 by something, 1 by 3 or 1 by 2 or 1 by 4? Will it be more than or less than 3 by 8? It will always be less than 3 by 8, no? So based on that logic, you can tell that the saturation, transferrin saturation is less. Okay, but then one thing, your stores in your iron deficiency anemia can be high. There are conditions in your iron deficiency anemia where your stores are high. Okay, and everything else is same. But because of this is the only problem. That is why we had to see all the other factors to differentiate between anemia of chronic disease. Any doubts in this anemia of chronic disease? Everyone got it? Which condition? You look up that condition. I don't know. I think it was something related to the absorption part, I guess. Some ankylostoma condition or something. I don't know. You please look it up. He just told that. I just read that it can be high. That is the only reason we need to. That is why you should not take it at face value. If serum ferritin is low, you should not tell it is iron deficiency anemia. Just like that. Okay. I'll look up and I'll let you know. If you guys are free, I can go ahead and I can tell you one more important topic, which blast. I'll tell you about sideroblastic anemia. This not required. I'm just doing this a little bit extra, but then you guys can leave. Okay, what is sideroblastic? Sideroblastic is something related to your iron. What is happening here is that you have uh, your cell, and then in that cell you have your cytoplasm and you have your mitochondria, right? There are few steps that happen in your mitochondria and few steps that happen in your cytoplasm. Since this mitochondria will be close to your nucleus, okay, in this mitochondria you have heme synthesis, okay, and protoporphyrin. You have synthesis of protoporphyrin, and with this protoporphyrin your iron will bind. This protoporphyrin and iron are supposed to be in adequate amounts to bind to each other. Let's say in your protoporphyrin production there is some issue, so there is very less amount of protoporphyrin, but there is more amount of iron. Will there be a production of hemoglobin? No, there won't be heme, right? There won't be heme production, but there will be more iron. This excess of iron will be there near your mitochondria, and when you stain it, you can see you can see rings because this iron is taking up that stain. Okay, that is called sideroblasts. These are called sideroblasts. This is called a ring sideroblast. Okay, now what is now? I'll ask you a question. First question: if at all I have more production, that is hyper proliferation, can I see sideroblasts? Yes or no? Yes or no? If I have more production, will I be seeing more sideroblasts? And if I have anemia, let's say anemia, very less production, hypoplastic marrow, hypoproliferative marrow, will I be seeing more or less sideroblasts? Normally, when you take a marrow biopsy, you're supposed to see about 30% of sideroblast. What does it say? It says that there is active RBC production that is taking place. If at all I take an aplastic marrow or in anemia, that time I say that there is hyperproliferative marrow and there are low sideroblasts. So one of your markers will become your sideroblast numbers. If at all it is more than 30%, that means it is normal. If at all it is less than 30%, that means it is iron deficiency anemia. Okay. Now I'll tell you a little bit about your treatment part. In your treatment part, how do you treat iron deficiency anemia? What is the first line of drug which you use? Let's say he has a deficiency of about 1300 milligrams. How will you treat it? Okay, whatever it is, whatever the condition is, whatever it is, first thing you need to do is you need to replenish his iron storage. Now what do you have? You have FeSO4, 200 milligrams tablet. Okay, now what I tell you about this 200 milligram of FeSO4 has only 60 milligrams of elemental iron. In this 60 milligrams of elemental iron, 10% only is absorbed. Since only 10% is absorbed, each tablet will give him only 6 milligrams. How long will it take for you to fill the deficiency of 1300 milligram? That is the reason any tablet, if they give iron tablets, they take it for a very long time. Okay. Now, is there any other alternative? Obviously there has to be, right? There has to be some alternative to this. That alternative is nothing but your iv iron. You can easily replenish about 200 milligrams of iron at one at one go. That is why They say if at all a person has come to you with an emergency, rather than just giving iron, if at all he has HB, let's say 6 or 5, that time you can't say I'll give him tablets and replenish everything. You need to give IV iron. Okay, that is how you treat. And this is not recommended a lot because this is more safer, less side effects. Now I'll tell you what kind of a person you should give IV iron. Since I told the therapy is very long, right? What will happen? Many patients, many ignorant patients like me will not take the therapy. So for people like who are non-compliant, for people who are facing an emergency, for people who have to go for a surgery, right? For them, I need to give IV iron. Okay, we'll end it here. That's all.